Thyroid nodule are a reasonably common presentation to a pediatrician or a physician, and they have significant issues in terms of diagnosis and evaluation. And these issues can result into very hazardous consequences if appropriate protocols are not followed, as was the case with this 10-year-old girl who presented with thyroid swelling, was clinically euthyroid. The pediatrician did a workup which showed a BPO being negative and was reassured, but came back a couple of years later to us with rapid growth and turned out to be a papillary carcinoma. So one needs to be very, very careful in terms of evaluation and follow-up of individuals with thyroid nodule. And although thyroid nodules are rare, they still are to the tune of around 2 to 4%. What's very important to understand is that while 90 to 95% of them would be benign, the chance of having a malignancy would be around 5 to 10%, emphasizing the need for careful assessment and management of these disorders. Thyroid nodule may represent a swelling which is a thyroidal origin, which may include most commonly the adenoma, a thyroglossal cyst, which is basically a developmental defect in the tract between the site of descent of the thyroid gland from the foramen cecum to the thyroid location, ectopic location of thyroid, and rarely malignancy, which is a major cause of concern. They may also represent other forms of swellings like teratoma, lymphomas, or thyroid cyst. So, from a pathophysiological perspective, we can consider thyroid nodules to be extrathyroidal, which includes things like teratoma, cyst, which have very limited chances of being malignant, thyroidal swellings, which may be benign in the form of adenomas, which may be producing thyroid hormone or may be non-autonomous, may be in the form of thyroglossal cyst, which are abnormalities associated with the site of descent of the thyroid gland. They are characterized by movement when we are protruding the tongue and when we ask the patient to swallow. Ectopic thyroid, which would be the thyroid gland which is located in the site of descent, and this may be the only functional gland which can sometimes erroneously be removed during procedure. It may be malignant, which the most common form is papillary carcinoma, and there can of course be other rare forms of follicular medullary carcinoma and lymphomas. So the three key questions which a physician has to answer while dealing an individual with thyroid nodule include: is it really a thyroid nodule? Is it autonomous or not? Because that has implications not only in terms of the effect of thyroid functions in the form of thyrotoxicosis and the impact on the individual, but also the fact that autonomous nodules are usually benign in nature and whether it is malignant. So if we just start, so thyroid nodule by definition is not a diffuse enlargement, it's an enlargement of one part of thyroid gland. And importantly, a number of thyroid nodules may not be palpable, but may be detected on an incidental basis while performing a carotid Dopplers, neck CT, or a PET scan. What's important to understand is that the chances of malignancy and the approach to the management does not change whether a nodule was identified from a clinical palpation or was identified based upon these incidental findings. The management is pretty much the same. There are some suggestions that nodules which represent an increased PET uptake may be more likely to be malignant. However, this needs to be confirmed. It's very important to exclude other forms of thyroid swelling, like this boy had a thyroid swelling since birth, which was mobile, had slight tenderness, and when we asked for movement of tongue, protrusion of tongue, it was moving, and this was suggestive of a thyroglossal cyst which had to be removed because of a high risk of malignancy. Now, once we know that this is a thyroid nodule, the next big issue is whether it is autonomous or not, and for that the TSH concentrations are most important. TSH concentrations are important not only to identify thyrotoxicosis, as the chance of malignancy is much less, but what we see from this classic study is that the risk of having malignancy in the thyroid nodule increases exponentially across the thyrotoxic to a euthyroid to a hypothyroid. So therefore, there is around 10 times greater risk of developing malignancy in a thyroid nodule if an individual has hypothyroid compared to an autonomic function. So autonomic function is extremely important thing to identify in a thyroid nodule. For that, TSH is of course the most important test, and if the level of TSH is less than zero point 0.1, it is most likely that the nodule is autonomous. Nuclear scan should definitely be done in this perspective to identify and characterize the lesion further. Ultrasound, as we'll discuss later on, is required for every individual with thyroid nodule. FNAC is usually not indicated in these features unless there are characteristic ultrasound features. However, there may be some nodules which are functional, but they are not functional enough to cause complete suppression of TSH. In that, TSH may be 0.1 to 1. Here, the autonomy is likely, but definitely nuclear scan may be of help in certain situations, as we'll discuss later on, particularly for the follicular neoplasm. And if it's a persistent finding of this level of TSH between 0.1 to 1. Ultrasound is definitely indicated, and fine needle aspiration should be suspected if there is a hypofunctional or an indeterminate display which happens on a thyroid scan. If TSH is more than 1, it is extremely unlikely to have an autonomous lesion. Nuclear scan has no role. There is a definite role of ultrasound, and ultrasound will then decide about the need for a fine needle aspiration. Thyroid scan is very commonly available, and we have the options of iodine 123 and technetium scan. Iodine 123 is associated with not only the uptake but also organification, and in most cases is superior as compared to a technetium scan, but technetium is something which is readily available. Based upon the radiographical picture or the picture on the nuclear scan, we can find an autonomous lesion which is defined as areas of increased uptake along with suppression of the remaining part of thyroid, and in this part there is no need of any further evaluation or of FNAC. We may also find a cold nodule in which there is some area of a filling defect which basically has low uptake compared to increased uptake throughout the gland. This is a very high risk of malignancy, and definitely a fine needle aspiration is required. What's important to remember is that many nodules may appear autonomous on technetium, but they would not be autonomous on iodine 123. So the general recommendation is that if there is an identification of a nodule which is increased in terms of thyroid uptake, but the remaining thyroid is not suppressed, in that situation, we need to follow up this technetium scan by a iodine 123 before going ahead with further evaluation. Very important thing to remember is that many of these scan modalities are essentially two-dimensional, and therefore there could be a situation therein there is a normal thyroid tissue which is there above that particular nodule, and this will result in an indeterminate picture. This happens if a nodule is not very functional so as to cause complete suppression of the gland, or the size of the lesion is less than 2 centimeters. So unless and until there is a clear-cut autonomy which is demonstrated on nuclear imaging, which is in the form of increased uptake by the nodule and complete suppression by the remaining part, and if the feature is indeterminate, there is definitely a need of a fine needle aspiration in this setting. We have this 14-year-old girl with a thyroid swelling which was reasonably big. It was mobile, associated with weight loss and tremors. And when we did an evaluation, we found that she had thyrotoxicosis. Very important to see that if we see out here is that there is a clear-cut increased uptake by the nodule, and the remaining part of the thyroid gland is suppressed. So this was a toxic nodule, and as there has been changes in terms of management, the best management for this girl would be a surgery. Importantly, radionuclear treatment, radionuclear ablation of the nodule in children may be associated with a danger of exposing the remaining thyroid gland to a low level of radiation, and because these individuals are sensitive to thyroid radiation, this may result in an increased risk of malignancy subsequently, and therefore there is a definite indication of surgery after stabilization of thyroid function in this situation. So now once we have shown that this is a thyroid nodule, it is autonomous or non-autonomous, the next issue comes is whether it is malignant. And there are 6 things which will tell us whether a possibility of a thyroid nodule being malignant. These include a careful history, examination, thyroid functions, nuclear scan, ultrasound of course is one of the most important, and fine needle aspiration. Now, clinical perspective will itself give us a lot of clues. So, what we can see from this old paper, which is quite relevant, is that children and particularly adults below 30 years have a higher risk of malignancy. However, as shown in this figure, the risk is not that high as 15 to 20% in children. More recent literature will suggest the risk is around double, definitely in that setting. If there's a past history of a head and neck radiation exposure, if there is a nuclear leakage and those areas in which there is increased exposure, or there is a total body or a head and neck radiation because of treatment for cancer, that really becomes important. If there's a family history of cancer or thyroid malignancy, or there are predisposition syndromes, which we have to definitely look at. Examination is very, very important. So if there is associated compression like vocal cord paralysis, size more than 1 centimeters, there is a rapid progression and a fixed nodule and a cervical lymph node, there is a high risk of malignancy in that particular nodule. One also needs to be careful in terms of evaluation for features of MEN2 in the form of mucosal neuromas and bumpy lips, Cowden syndrome, particularly of the various skin rashes, and a possibility of a Carney complex associated with ACTH-independent Cushing syndrome, testicular tumors, myxomas, and lentigens. Thyroid functions, as discussed earlier, do tell us the risk of not only having a malignancy in a given thyroid nodule, they also are associated with prediction for the risk of invasiveness. So higher TSH is associated with a greater chance of a thyroid lesion being more aggressive and more metastasizing. And this is something which is really easy to understand given that TSH is the most important growth factor for the thyroid gland. So nodules which are exposed to a higher level of TSH will of course have a greater chance of becoming malignant as well as becoming more aggressive from that perspective. The next of course is nuclear scan, and on nuclear scan if we have a cold lesion which is a filling defect or an indeterminate lesion, there is a definite role of further evaluation with a fine needle aspiration. Having said that, these 4 criteria of history, examination, thyroid function, and nuclear scan would be giving us a clue for malignancy in maybe 5 to 10% of cases. The most important investigation which will really guide us towards further evaluation and management happens to be a thyroid ultrasound. And thyroid ultrasound should ideally be done, of course, by individuals who are pretty doing it more frequently and are experts on that. It should be done pretty much in every individual who comes to us with thyroid nodule. The advantages of ultrasound over other imaging modalities, including CT scan, is that it gives a very good information about the posterior nodule. A cystic and solid area nodule is also something which we get very well. The role is to decide about the need for FNA. It can also help us in terms of guided aspiration. The key things to look at in terms of ultrasound is to confirm that there is nodularity, and often if there is a goiter, whether there are nodules within the goiter which may require evaluation, look at sonographic features indicating malignancy, look for additional nodules and lymph nodes. The 2015 American Thyroid Association criteria give tremendous guidelines with regards to the sonographic features and how these features can actually be predictive of malignancy, so to speak. What they give the most importance, of course, is that if there is a solid and a hypoechoic, solid and a dark lesion, there is a high risk of malignancy. If this is associated with an irregular margin, a taller and wide appearance in adults, this is of course not important in children, and this is what we'll talk later on, microcalcification, or broken rim calcification. So all of these, irregular margin, taller than wide, microcalcification, and rim calcification in a lesion which is solid and hypoechoic, has a 70 to 90% risk of malignancy. So they need to be very, very cautiously evaluated. On the other hand, if we have just a solid and a hypoechoic lesion, which is regular margin, no calcifications, no broken rim, the risk is around 20 to 20%. Milder appearances on ultrasound includes a hyperechoic or an isoechoic lesion and a combined solid to cystic area. The malignancy risk becomes less than 3%. So what they're trying to do is that it's not just the size which is the criteria, it is the size and the sonographic appearance which provides information about the need for further evaluation for lances of malignancy, in particularly FNAC, and therefore the size criteria may differ based upon the sonographic findings, and this is something which we'll discuss subsequently. If there is a pure cystic lesion, the malignancy chance is less than 1% and probably there is no need for FNAC. So what do we do? If there is a cystic lesion or the lesion is less than 0.5 centimeters, there is usually no need to do a FNAC. On the other hand, if there is an extrathyroidal involvement, if there are compression which is seen on ultrasound, if there is extrusion from the thyroid by that lesion, or if there is an abnormal lymph node, there is a definite node of a need for FNAC irrespective of the size of the lesion. Now, if otherwise the lesion is more than 2 centimeters and above for spongiform nodules, more than 1.5 centimeters for lesions which are hyperechoic or isoechoic or mixed solid cystic areas, or more than 1 centimeters for any lesion which is solid and hypoechoic. If there is associated, of course, with microcalcification, with irregular margin, it becomes more important. So the crux of the ATA guidelines with regards to thyroid nodule evaluation are that size is important, but if a lesion has very invasive characteristic as seen in the right hand corner by being compressive, by extruding, by abnormal lymph node, any size requires evaluation. The conventional criteria of 1 centimeter holds for any lesion which is solid and hypoechoic. So solid, dark, more than 1 centimeters do an FNAC. If there is irregular margin, if there is microcalcification, if there is rim calcification, you have to be very, very cautious. If the lesion is not hypoechoic, so if it is solid cystic combined, if it is associated with iso or hyperechoic, the criteria can go up to 1.5 centimeters, and for spongiform nodules, the criteria can be above 2 centimeters. Very small lesions and lesions which are purely cystic do not require a fine needle aspiration. So this is a very, very clear-cut guidelines as far as the ATA criteria are concerned. There are other ways to look at. There are the TRAD scoring, which are done by the American Radiology Society, by the European, by the Korean Society, and they use specific pointers for the composition, the echogenicity, shape, margin, and echogenic foci. So all of them are given scoring, and based upon the scoring, they are then graded into different parts, and then decision is required with regards to the biopsy threshold. So what they're trying to say is that if they are all cystic, anechoic, not wider than tall, smooth, and no echogenic foci, the score is 0. The malignancy risk is very less. There is no need for biopsy. Similarly, if the lesions has a score of up to 2, so you may have some mixed cystic and solid, it may be hyperechoic or isoechoic, you may still not do a FNA. But as soon as the score goes beyond 2, so if somebody has taller than wide, let's say that becomes directly 3. Or if there is hypoechoic with cystic solid, the criteria goes to 25, which is 2.5 centimeters. And as score increases, the time intervention point at which the FNA is done comes lower. Now, there may be some ultrasound features which do not require FNAC to begin with, but we need to follow them up importantly. So if they are suspicious features on ultrasound, if the size is less than 1 centimeter, so you did not do a FNA, then repeat a ultrasound after 6 to 12 months. If they are low to indeterminate lesions, so they are like isoechoic, not that much concern after 12 to 24 months, and very, very low risk, it will be 2 to 3 years. On follow-up, final aspiration is indicated if the size increases as per the particular criteria and the sonographic features. So ultrasound therefore is a very important modality which helps us decide the need for FNAC, but the ultimate diagnosis of malignancy is of course done based upon the final aspiration, and the final aspiration has to be done under expert hands, and there are few things which we need to consider. If the lesion is more than 4 centimeters, there may be a risk that it may have a false negative appearance on FNAC, so best would be to take it from multiple areas so that the affected areas is not lost. If there are multiple nodules, so if there is a multinodular goiter, the risk should be individually assessed for each nodule, and if there are no specific features suggesting malignancy, then the largest nodule should be FNA'd. If there is a non-diagnostic FNA, which is a reasonably common phenomena, we should do the next one, which is ultrasound guided, as well as in every pediatric case, those which have a posterior nodule and a predominantly cystic nodule should also have a ultrasound guided final aspiration. Now, once the FNA has been done, it is very important to stick to specific histological criteria, and the Bethesda classification classify these into 6 criteria. And these categories are basically different because of their malignancy risk and treatment plan. So if the FNA is non-diagnostic because of sparse or whatever reason, the malignancy risk is still there up to around 5%. The options include to do a repeat FNA, and if repeat FNA is not working, it may be better to go ahead with a core biopsy, which is ultrasound guided. However, if these are again non-diagnostic, in most situations, if they are large, we should go ahead with surgery, or if the increase is more than 20%, we need to be more cautious in this regards. There may be a benign appearance on cytopathology, which is basically very low risk of malignancy. The indications in this case would be to do a follow-up ultrasound after 12 months. FNA should be routinely done if the ultrasound was suspicious to begin with after 12 months, or if the size increases by 20 centimeters in any dimension, or the volume increases by more than 50% during this period. The most confusing picture, and this we'll discuss later on, comes on when we have the stage 3 and 4, which is atypia of undeterminate significance or follicular lesion of undeterminate significance, and what was earlier known as follicular neoplasm. These have a reasonable risk of malignancy, 10 to 40%, but still does not mean that all of them should go for surgery, because 90% cases may actually not require surgery in this case. So there have been conventionally a repeat FNA after 6 weeks, and if molecular studies are available for different molecular markers of malignancy, they may be considered, and they may decide about the prognostication and the need for surgery under this setting. If there is a suspicion for malignancy, surgery is something which is required because there is a very high risk of malignancy. Molecular studies are not indicated to decide about the need for surgery, but they may help decide about the plan, whether it's a diagnostic or a therapeutic surgery. If there is a malignant lesion, of course, the chance of malignancy is very high and has to be a therapeutic surgery in this setting. So molecular studies are emerging as a way to prognosticate the risk for malignancy in thyroid nodules, and they are typically indicated in category 3 and 4, which includes atypia of undeterminate significance, follicular lesion of undeterminate significance, and follicular neoplasm. And they include a number of arrays by which the exome and the RNA sequence are done, and based upon the specific risk genes like BRAF, RET, PET, PTC, and their expression, the risk of malignancy is taken, and if the risk is high, they go more in favor of surgery, while the risk is less, we can do a more conservative follow-up. So the American Thyroid Association of 2015 guidelines clearly mentions that for this situation, molecular testing may be an option in deciding about the risk assessment, and if this option is not available, the diagnostic surgery is what is recommended. So just to summarize the overall approach, every individual with a thyroid nodule should be evaluated comprehensively clinically, TSH and ultrasound. If the TSH level is low, and by that we mean if it's less than 0.1 or between 0.1 to 1 in somebody who has a follicular lesion of unknown significance, the workup should be thyroid scan. If it shows the increased uptake, there is definitely a need for surgery and potentially radioactive iodine. If it's a cold or an unclear or indeterminate lesion, we need to go ahead with the FNA. If the size is more than 1, if the TSH is more than 1, we should go by the size and ultrasound criteria. So if it's less than 0.5 centimeter or cystic, no FNA is required. If it's between 0.5 to 1 with invasive, like extrathyroidal, suspicious node or compression. If it's 1 to 1.5 with suspicious features like taller than wide, microcalcification and irregular margins. 1.5 to 2 with mild features like isoechoic or hyperechoic, and more than 2 with spongiform, FNA should be done. If FNA is non-diagnostic, it should be repeated, or if it's a large lesion, to consider for surgery. If it's benign, one should follow up. If it's category 3 and 4, atypia of unknown significance, follicular lesion of unknown significance, or follicular adenoma, molecular studies if possible, and surgery. And if it's suspicious or malignant, of course, surgery is the treatment of choice. Now, pediatric thyroid nodule poses significant challenges because the risk of malignancy is significantly higher. Earlier, the figure was quoted to be around 20%, now it's around 10 to 15%, and it tends to be more invasive. However, despite being more invasive and associated with greater hematogenous and nodular spread, pediatric thyroid cancer has got a good response to therapy. So identifying it at a right time is very helpful. In this regard, what we need to understand is that imaging becomes important, and even if the size is below 0.5 centimeters or 0.5 to 1 centimeters, one need to be very, very cautious in considering FNA if there are characteristic features there. Very importantly, features like calcifications, like rim calcification, taller than wide appearance are not suggestive of malignancy in children, and abnormal lymph nodes may actually be the important feature suggestive of malignancy. So if there is a solid hypoechoic lesion, we have to be very aggressive in terms of evaluation in children. The cytopathology, once it's decided upon, is associated with a 22% malignancy rate, and there needs to be an aggressive approach. Similarly, there is, as discussed earlier, surgery is the preferred modality for treatment of toxic nodule, and we also need to be aware that a significant number of them may have a genetic or a syndromic association, implying careful follow-up. So if you go into the pediatric nodule, clearly surgery is the indicated treatment for toxic nodule. We need to be careful about smaller lesions because the size of thyroid may be small, and features like taller than wide, microcalcification, and irregular features are not characteristic of malignancy in children. Surgery is definitely something which we will go more forward in terms of suspicious lesions because of the higher risk of malignancy. For pregnancy, the characteristics are pretty much similar to non-pregnant women, but they may show some increase in size. So generally the evaluation is deferred unless there is a very high risk of development. Second trimester evaluation and surgery is rarely done, typically if there are compressive features. So if we compare the management of thyroid nodule in pregnancy, there is no role of thyroid scan, of course, because it's contraindicated. FNA should typically be deferred till second trimester, and surgery is only indicated for progression. So thyroid nodule is something which we need to be really cautious about because there is a high risk of malignancy. TSH and ultrasound is essential in every individual. Nuclear scan should be done if the TSH level is low. FNA decision should be guided by the ultrasound and size. The Mediclasses app has a specific section which basically talks about the thyroid nodule and the approach pathway, which really tries to go through the same principles that we discussed here and uses these various modalities how to manage a thyroid nodule. So it basically looks into the various aspects of that in this perspective. So if we really go into that, that will really help out in terms of further evaluation and management. So if we go for a thyroid nodule, it will basically ask about the TSH level. Based upon the TSH level, it will ask about the size, and based upon the size, the risk of malignancy on ultrasound, and then there will be a decision as to what the diagnosis has come up.